Okay, imagine this. You've got a client, just came out of surgery, half an hour ago, pretty stable. Temp 98.9, BP 142 over 78, heart rate 98, respirations 14, O2 sat 95%. Looking okay.
Mm-hmm. Standard post-op picture.
But now, things have shifted. Temps down a bit, 98.2. BP, though, tanked, 95 over 54.
Whoa, that's a drop.
Yeah, and heart rate's jumped to 118, breathing's faster at 18, O2 is down to 92%. So what do you do?
That's the critical question, isn't it? That sudden change is exactly why monitoring is so vital.
Exactly. And that scenario, it's pulled right from our source for today, the Saunders Comprehensive Review for the NCLEX-PN Examination, 7th Ed. That's our launch pad.
The perfect example shows how dynamic things can be, even hour to hour, especially post-surgery. It really drives home that vitals and labs aren't just numbers on a chart.
Right. It's about seeing the patterns, the changes, and figuring out, well, what does this mean?
Precisely. And that's our goal today, really digging into this chapter. We're pulling out the key stuff, vital signs, lab values, what they mean.
Yeah, whether you're actually in healthcare or maybe you're just trying to understand your own health stuff better or even just curious. This is about breaking down these basics.
Making it digestible. Because honestly, knowing this stuff helps you understand health information better. See how it all connects. It's foundational.
Okay, so let's start right there. Foundations, vital signs. What are we really looking at when we take these?
Well, fundamentally, they're physiological flags, right?
Yeah.
Indicators of the body's core functions. We're talking temperature, pulse, respirations, blood pressure, oxygen saturation, pulse ox, and crucially, pain.
Pain as a vital sign, yeah.
Absolutely.
Right.
Together, they give us that initial baseline snapshot, but also let us track changes, see if someone's status is shifting.
Now, about actually getting those numbers, who does what? Can a nurse just hand off these tasks?
Ah, good question. So, taking the temp, pulse, respirations, BP, even pulse oximetry. Yes, that can often be delegated to, say, unlicensed assistive personnel, a UAP.
Okay, so they can take the measurement.
They can collect the data, yes. But, and this is the critical part, interpreting those numbers, figuring out what they mean in the context of that patient. That absolutely stays with the nurse. It's a professional responsibility.
Gotcha. Data collection versus clinical judgment makes sense. And how often do these need checking? Is it set in stone?
Usually, the primary healthcare provider, the PHCP, sets a frequency. But the nurse has to use their judgment too. If the patient's condition changes or seems unstable, the nurse can decide to check more often.
So it's flexible based on the patient.
Exactly. And regardless of who sets the schedule, documenting every single reading is essential. Plus, reporting any abnormal findings right away to the RN, to the PHCP. That's key.
Okay, so documentation and reporting are non-negotiable. What about the when? Specific times vital signs are a must.
Definitely. There are key moments. First off, initial contact like admission, always.
Baseline.
Right. Then, as part of any physical data collection, and really importantly, before and after any kind of invasive procedure or surgery.
Pre and post comparison, yeah.
Exactly. You need that baseline to see if the procedure had an effect.
Yeah.
Also, during medication administration, specifically meds that affect the heart, breathing, or temperature, before, during, after sometimes.
Makes sense for monitoring drug effects.
Same goes for blood transfusions, before, during, and after. Any time a patient's condition just seems different, you reassess.
Even subtle changes.
Yeah. Even after interventions like, say, helping someone walk for the first time post-op, check how they tolerated it. And finally, if someone has a fever or a known infection, you're checking frequently, maybe every 2 to 4 hours, to track things.
Okay, that paints a clear picture of the timing. Let's dive into the specifics now, starting with temperature. What's the normal range we're thinking about?
Generally, for adults, we're looking at 36.4 to 37.5 degrees Celsius. That's about 97.5 to 99.5 Fahrenheit.
And the classic 98.6 F.
That's the average oral temp, yeah, 37.0 Celsius. But remember, the site matters. Rectal temps tend to be a bit higher, maybe a degree Fahrenheit higher,
Right.
while axillary under the arm is usually about a degree lower than oral.
Right. Context is key. And conversion formulas are in the source if needed. But it's not just the site, is it? What else bumps temps up or down?
Oh, lots of things. Time of day is a big one, lower in the morning, peaks late afternoon usually.
Body clock stuff?
Mm-hmm. Environment temperature matters too, obviously. Age, babies, and infants fluctuate more. Exercise definitely raises it.
Okay.
Hormones play a role. Think menstrual cycle. Pregnancy tends to run a bit higher. Stress can increase it. And of course, illness, infection, that's the classic fever trigger.
And on the flip side, a really low temp. or even being unable to get a reading.
Yeah, significant hypothermia is serious, especially in the very young or old. And if you can't get a reading on someone who seems sick, don't just ignore it. That could signal severe problems like poor circulation or shock.
Good point. Don't dismiss difficulty getting a reading. Okay, methods. Oral is probably most common.
It often is, yeah. Convenient.
Yeah.
But you need accuracy. So if someone just had hot or cold drinks or smoked or chewed gum, you gotta wait maybe 15, 30 minutes.
To let the mouth temp normalize.
Exactly. And placement matters too. Under the tongue, in that back pocket, lips closed, no biting.
Right. What about rectal temps? When would you use that, and what are the cautions?
Rectal's an option when you can't get a good oral reading. Maybe they're congested, had mouth surgery, wired jaw, NG tube, can't close their mouth, or risk seizures.
Okay, specific situations.
Yeah. Privacy is key, of course. Sims position usually lying on the left side, right knee bent up. Lubricate the thermometer. Insert gently about 1.5 inches for adults, less for infants, like half an inch.
But there are times you shouldn't use rectal.
Absolutely. Big contraindications.
Yeah.
Cardiac patients, risk of vagal stimulation slowing the heart. Recent rectal surgery, obviously. Diarrhea, impaction, rectal bleeding, or if they have a high bleeding risk. Avoid it then.
Very important safety points. Okay, axillary, under the armpit.
That's an alternative if oral and rectal are out.
Yeah.
But it's generally seen as less accurate than the others.
Less reliable.
Yeah. Make sure the axilla is dry. Place the thermometer right in the center. Have them hold their arms snug against their chest. And follow the device instructions for timing. It varies.
Got it. What about the ear? Tympanic temperature.
For tympanic, first thing is to look in the ear canal. Any redness, swelling, discharge, foreign object. If so, don't use that ear.
Makes sense.
Also, an ear infection or even a lot of earwax can mess with the reading. And technique matters, getting a good seal with the probe.
Okay. And the last one, temporal artery. Across the forehead.
Right. Forehead needs to be dry. Place the probe flush, slide it smoothly across the forehead over the temporal artery area.
What if they're sweaty?
Good question. If they're diaphoretic, the instructions usually say you can use an alternative spot, often behind the earlobe on the neck. So you got to follow the specific device guide. Consistent skin contact is key.
Excellent overview of temperature. Let's move to pulse. What are we assessing here, fundamentally?
Pulse is basically counting the heartbeats per minute, felt as that waves in an artery. Average adult rate is 60 to 100 beats per minute.
The standard range.
Yep. But it tells us more than just rate. We're checking rhythm, strength, and assessing peripheral pulses, like in the feet, the pedal pulses, is crucial for checking circulation down there.
And if you can't feel it well?
That's where a Doppler ultrasound comes in handy. It amplifies the sound of the blood flow, helps you find those weaker pulses. Pulse also tells us how someone's tolerating activity, stress.
Like temperature, pulse isn't static either, right?
Right.
What influences it?
Lots of factors. Age tends to slow down a bit as adults get older. Exercise definitely speeds it up temporarily.
Naturally.
Emotions too, stress, anxiety, excitement. Kick in the sympathetic nervous system, raise the rate. Pain often does the same.
Body's response.
Fever usually increases pulse rate too.
Right.
Medications are big ones. Stimulants raise it, depressants, and some heart meds like beta blockers or digoxin slow it down.
Okay.
Low blood pressure often triggers a faster pulse, the body trying to compensate. And blood loss, like hemorrhage. Pulse rate shoots up.
When we check the pulse, it's more than just counting, you said. What else are we noting?
Yeah, rate is just one piece. Rhythm is vital. Is it regular? Irregular. Skipping beats. And strength, the force or amplitude.
How do we describe strength?
There's a common grading scale. Usually 0 to 4 plus Satch is 0 is absent, no pulse felt. Then 1 plus is weak, thready. 2 plus is normal, easily felt. 3 plus is strong. And 4 plus is bounding really forceful, might suggest high cardiac output or fluid overload.
Okay, that scale helps quantify it. And where are the main spots we check pulses?
Several key points. Temporal, on the head. Carotid, in the neck, but gently, one side at a time. Don't want to cut off brain flow.
Good caution.
Apical pulse, that's listening right over the heart apex with a stethoscope, usually left side, fifth intercostal space, mid-clavicular line.
Listening, not feeling.
Correct. Then brachial, in the elbow bend. Radial, on the thumb side of the wrist, very common. Femoral, in the groin. Popliteal, behind the knee. Posterior tibial, inner ankle. And dorsalis pedis, top of the foot.
Lots of options. When is counting the apical pulse for a full minute essential?
Critical in certain cases. If the radial pulse feels irregular. If the patient has a known heart condition. Before giving specific heart meds like digoxin or beta blockers. And in kids under 2, their peripheral pulses can be tricky to count accurately.
You mentioned apical versus radial. What's a pulse deficit?
A pulse deficit is when the radial pulse rate is lower than the apical pulse rate counted at the same time.
Meaning not every heartbeat is reaching the wrist.
Exactly. Suggests maybe the heart contractions aren't strong enough to perfuse well, or there's some other issue. You usually need two people to check it. One listens apically, one feels radially simultaneously.
And if you find a difference?
Report it. A significant deficit needs follow-up, could indicate a problem with cardiac output.
Okay, good to know. Let's switch to respirations. Normal rate for an adult.
Generally, 12 to 20 breaths per minute is considered normal for adults. Like pulse, it's much faster in infants and gradually slows down through childhood.
And what affects how fast or deep someone breathes?
Similar factors to pulse, actually. High CO2 levels or low oxygen levels in the blood. That stimulates the brain to increase rate and depth.
Body trying to compensate.
Right. Conversely, things like head injury or increased pressure in the skull can depress the respiratory center, leading to slow, shallow breaths.
And medications.
Opioids are the big ones known for respiratory depression. Anxiety, pain, exercise can all increase rate temporarily, too.
How do we measure respirations accurately? It seems like people might change their breathing if they know you're watching.
That's the trick. Best way is often right after checking the radial pulse. Keep your fingers on the wrist like you're still counting, or rest your hand gently on their chest or abdomen and watch the rise and fall.
Be subtle about it.
Exactly. Count one full cycle, one inhale, one exhale as one breath. Usually count for 30 seconds and multiply by 2. Unless the breathing is really shallow or very fast or irregular, then count for a full 60 seconds to be accurate. And don't just count rate. Note the depth, shallow, normal, deep, the pattern, irregular, irregular, and listen for any weird sounds like wheezes or crackles.
Good comprehensive assessment. Okay, blood pressure. We always hear two numbers, systolic and diastolic. What do they mean?
Right. Blood pressure is the force of blood pushing against artery walls. Systolic is the peak pressure when the heart contracts and pumps blood out.
The top number.
Yep. Diastolic is the lower pressure when the heart relaxes and fills between beats, the bottom number.
And the difference between them.
That's the pulse pressure. Gives clues about stroke volume, vessel elasticity. Normal BP for adults is generally less than 120 systolic and less than 80 diastolic.
And higher numbers lead to classifications like prehypertension, hypertension.
Correct. Stage 1, Stage 2 hypertension. The source details those ranges. We also need to think about postural or orthostatic hypotension.
That dizzy feeling when standing up.
That's often the symptom, yeah. It's a significant drop in BP when moving from lying or sitting to standing. We measure BP and pulse lying down, then sitting, then standing, waiting a minute or 3 between positions.
Looking for that drop.
Yeah, a drop of 20 millimol of Hg or more systolic or 10 or more diastolic usually indicates orthostatic hypotension.
Okay. Like other vitals, BP fluctuates. What factors affect it?
Lots of things influence BP. Age tends to creep up as we get older. Vessels get less elastic. Stress, anxiety definitely can raise it temporarily.
Fight or flight.
Yep. Race is mentioned higher rates of hypertension in African Americans, though the reasons are complex. Medications, obviously antihypertensives lower it. Some cold meds or high-dose NSAIDs might raise it. Opioids can lower it too.
Daily patterns.
Diurnal variation, usually lowest in the morning during sleep, peaks late afternoon, evening. Sex plays a role too, typically lower in women than men before menopause. Then that can flip after menopause.
Okay, lots to consider. When actually taking the BP, what are the key guidelines for accuracy?
Accuracy is paramount. First, pick the right site, usually upper arm, brachial artery. But avoid arms with IVs, shunts or fistulas for dialysis, arms on the side of a mastectomy or lymph node removal, or arms with injury or disease.
What if you can't use either arm?
Leg is an option. Use a thigh cuff, listen over the popliteal artery behind the knee.
Preparation?
Patient should be relaxed, no smoking, caffeine, or heavy exercise for about 30 minutes before. Rest for 5 minutes. Sit or lie comfortably, arms supported at heart level, legs uncrossed. No talking during measurement.
And the cuff itself?
Crucial. Wrap it snugly, evenly, lower edge, about an inch above the elbow crease. And size matters. Too small gives a falsely high reading. Too large gives a falsely low one.
Okay, correct size is key. Then listening.
Use a stethoscope that fits well. Deflate the cuff slowly, about 2-3 millimilli Hg per second. Listen for the carotid cuff sounds. Phase 1, the first clear tapping, that's systolic. Phase 5, when sounds disappear, that's diastolic in adults. And always document which arm patient position.
Very systematic. Okay, next vital sign, pulse oximetry. What's this telling us?
Pulse ox gives us a non-invasive look at oxygen saturation, SO2. It's the percentage of hemoglobin in the arterial blood that's carrying oxygen.
So how well oxygenated the blood is.
Exactly. Normal is usually 95 to 100% for healthy folks. The cool thing is, it can often detect low blood oxygen, hypoxemia, before you see obvious signs like blue lips or gasping. It's an early warning system.
How does it work? Where do you put the sensor?
The sensor clips on, usually a finger, toe, earlobe, sometimes nose or forehead. It shines light through the tissue.
Simple enough.
Yeah. The monitor shows the saturation percentage, often pulse rate too. Keep the sensor around heart level if possible. Make sure blood flow to the site isn't blocked. Poor circulation, tight dressings, even shivering can affect readings.
And if the reading is low? Like below 90%?
Generally, yeah, below 90% needs attention. Notify the PHCP. Though some folks with chronic lung disease might have a lower baseline that's normal for them. Always follow agency policy and provider orders.
Okay. Last vital sign, pain. Very different from the others, very subjective. How do we assess it?
That subjectivity is key. Pain is whatever the person experiencing it says it is. We categorize it often by duration: acute pain, short-term, from injury or surgery. Chronic pain lasts months or years, often with long-term illness. And phantom pain, after an amputation.
So how do we get information about something so personal?
You have to ask. Ask them to describe it. Intensity using a scale. Quality: sharp, dull, aching, burning. Location: where exactly. Frequency: constant, intermittent.
At the details?
Yes. Also ask about things they do that help, including alternative therapies. And watch for nonverbal cues, especially if they can't tell you.
Like in older adults or nonverbal patients.
Exactly. Older adults might show pain differently: sleep problems, changes in walking, being less social, depressed even. Nonverbal signs can be grimacing, moaning, being restless or tense, guarding the area, changes in vital signs sometimes. Our source lists these.
And pain scales.
Very helpful. Number scales, 0 to 10, are common. Picture scales, like the FACES scale, work well for kids or those who struggle with numbers. Always reassess after you do something for the pain to see if it worked. And remember, culture can influence how pain is expressed.
Okay. Assessment is key. What about non-drug ways to manage pain?
Lots of options there. Cutaneous stimulation, things like heat, cold, pressure, vibration. Massage or therapeutic touch can help, though might need an order.
10 TNS units?
Yep. Transcutaneous electrical nerve stimulation. Uses low voltage current to block pain signals. Needs an order. Binders, slings, support devices can ease pain from strains, sprains, surgery. Elevating limbs helps reduce swelling.
Heat and cold seem pretty common.
They are. Good for muscle strains, spasms. Again, may need an order. Use presses, pads, baths. But be careful, monitor skin temp. Risk of burns, especially with kids or older adults. Use a barrier, like a towel. Limit application time, usually 15-30 minutes. Tell them to remove it if sensation changes.
Safety first. What about complementary or alternative therapies?
Those can be great too. Often focus on mind-body connection. Might need an order. Always ask about herbal remedies' potential interactions. And respect spiritual practices that bring comfort.
Good holistic view. Now, the pharmacological side. Let's start with non-opioids.
Okay, so you have NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen, naproxen, and aspirin. Also acetaminophen.
How do NSAIDs and aspirin work, and what are the risks?
They reduce inflammation, block pain signals, partly by inhibiting prostaglandins. Big contraindications. History of stomach irritation, ulcers, allergy. And a major risk is bleeding. Use cautiously with bleeding disorders or anticoagulants.
Take with food.
Often recommended, yeah, or milk, to reduce stomach upset. They can also increase anticoagulant effects and potentially cause low blood sugar with some diabetes meds, like ibuprofen. Ibuprofen might also have issues with calcium channel blockers.
Okay. What about acetaminophen? Different mechanism.
Yeah, it works more centrally in the brain. Good for mild, moderate pain and fever. But the big concern is the liver. Exactly. Contraindicated in severe liver or kidney disease, alcoholism. Check liver history. Monitor for nausea, vomiting, abdominal pain. Limit self-medication. Duration risk of liver damage with overdose is serious. Acetylcysteine is the antidote.
Got it. Now, opioids. For more severe pain, but with more serious side effects.
Right. Morphine, hydromorphone, codeine, oxycodone. They work on opioid receptors in the brain and spinal cord to block pain perception. But they also affect other things.
Like breathing.
That's the main one. Respiratory depression is a major risk. They also suppress the cough reflex. Common side effects include sedation, euphoria, constipation, nausea, and potential for dependence with long-term use.
So, critical monitoring needed.
Absolutely vital. Give it 30-60 minutes before painful activities if possible. Monitor respiratory rate very closely. Hold the dose and notify provider if it drops too low, like below 12 breaths per minute in an adult, but check policy.
What else to monitor?
Heart rate can cause bradycardia. Blood pressure can cause hypotension. Lung sounds. Level of consciousness, watch for oversedation. Safety precautions for falls due to dizziness.
Yeah.
Monitor intake output for urinary retention.
Practical tips.
Take oral forms with food milk. Avoid driving or activities needing alertness. Always check if the pain relief is adequate. And crucially, have the reversal agent, naloxone, oxygen, and resuscitation gear ready. Use infusion pumps for continuous IV or PCA.
Are there specifics for certain opioids, like codeine?
Yeah, codeine is often used for cough at lower doses, but known for causing constipation. Hydrocodone, oxycodone are common synthetics, often combined with acetaminophen.
Hydromorphone, morphine.
Hydromorphone is potent. Respiratory depression is the primary concern, plus drowsiness, dizziness, orthostatic hypotension. Morphine is a go-to for severe pain like heart attacks, cancer pain, even shortness of breath and pulmonary edema. Major concern again is respiratory depression.
Other morphine effect.
Postural hypotension, urine retention, constipation, pinpoint pupils. Nausea, vomiting can happen. Contraindicated with severe breathing problems, head injury, severe kidney disease, seizures, increased intracranial pressure. Monitor urine output, bowel sounds, pupil size closely.
That's a really thorough look at pain. Okay, shifting gears now to another big section in the chapter, lab reference intervals. Why is understanding these lab values so critical?
Oh, it's fundamental.
Yeah.
These reference intervals, the normal ranges, tell us what's typical in healthy people for stuff in blood, urine, etc. When a patient's result falls outside that range, it signals something might be wrong. Imbalance, disease, medication effect.
Helps with diagnosis and treatment.
Exactly. Guides treatment, helps spot complications early. You can't interpret results without knowing the reference points.
The source mentioned some general tips for drawing blood samples.
Yeah, important stuff for accuracy. Big one. Avoid drawing from an arm with an IV running. The fluid can dilute the sample or mess up the results depending on what's in the IV.
Makes sense. Anything else?
Leaving the tourniquet on too long. That can concentrate the blood cells and some substances, potentially giving falsely high results for things like potassium. So, minimum time necessary.
Good practical points. Okay, let's look at specific labs. Serum, sodium.
Sodium, the main cation, positive ion outside the cells. Crucial for fluid balance, maintaining osmotic pressure. Also key for nerve impulses, acid-base balance.
Where do we get it? How is it controlled?
Mostly diet, absorbed in the small intestine. Kidneys regulate it, excreting more or less depending on intake and body needs. Normal range is generally 135 to 145 milliequivalents per liter, MEQL.
Okay. Next, serum potassium.
Potassium, the main cation inside the cells. Vital for water balance within cells, electrical conduction in muscles, especially the heart, and acid-base balance too.
Also from diet.
Primarily. Kidneys regulated closely. Checking potassium is key for heart, kidney, GI function, and guiding 5E replacement if needed. Important to note if someone's on supplements.
Any pitfalls in measurement?
Sometimes, very high white blood cell or platelet counts can cause a falsely high potassium level in the lab sample itself. Normal range is usually 3.5 to 5.0 millieql.
All right, moving to coagulation tests. Activated partial thromboplastin time APTT. What's that for?
APTT looks at the intrinsic and common pathways of the clotting cascade. Basically, how long it takes plasma to clot under specific lab conditions.
What does it help screen for?
Deficiencies or inhibitors of most clotting factors except 7 and 13. Clinically, it's most often used to monitor heparin therapy, the anticoagulant.
Heparin monitoring. Got it. Normal range.
Usually around 28 to 35 seconds, but it varies a bit by lab. If monitoring intermittent heparin, draw the blood about an hour before the next dose. Don't draw from the arm heparin is infusing into.
Your important logistical point.
Yeah. Transport the sample quickly. Hold pressure on the site for 3 to 5 minutes after. Therapeutic range for heparin is typically 1.5 to 2.5 times the normal control value. If it's way too long, say over 87.5 seconds or per policy, bleeding precautions are needed.
Okay. What about prothrombin time, PT, and the INR? How are they different?
PT looks more at the extrinsic and common pathways. Prothrombin is made in the liver, needs vitamin K. PP measures clotting time after adding different regions than APTT.
And the INR.
International Normalized Ratio. It standardizes the PT result because different labs use slightly different reagents, makes results comparable across labs.
What's PT-INR used for mainly?
Primarily for monitoring warfarin Coumadin therapy. Also screens for issues like liver disease, vitamin K deficiency, DIC. Normal PT is usually close to the lab's control, maybe 11, 12.5 seconds. Normal INR for someone not on warfarin is around 0.8 to 1.2.
And therapeutic ranges for warfarin.
Usually aiming for an INR of 2.0 to 3.0 for standard therapy, like for DVT or AFib. Maybe higher, 3.0 to 4.5 for things like mechanical heart valves. Get baseline before starting therapy. Same pressure precautions after drawing blood.
Anything affect PTINR?
Heparin can briefly affect it. Diet high in vitamin K green leafy veggies can lower the INR, make the blood clot faster. If PT or INR gets too high, above the therapeutic range, bleeding precautions again.
Okay, clear difference between APT-heparin and PTINR warfarin. What about platelet count?
Platelets are tiny cells crucial for stopping bleeding. They form the initial plug at an injury site, help the clot retract, activate other factors, made in the bone marrow.
Normal count.
Typically 150,000 to 400,000 per cubic millimeter. If someone's low thrombocytopenia, monitor venipuncture sites carefully for bleeding.
What can affect the count?
High altitude, cold weather, exercise can sometimes raise it slightly. Chemotherapy is a big cause of low platelets, so counts are monitored closely then. Bleeding precautions are based on how low the count is, per facility policy. Always check platelets and coag studies before invasive procedures.
Right. Hemoglobin and hematocrit, H&H.
Hemoglobin, the protein in red blood cells carrying oxygen. Hematocrit, the percentage of blood volume that's red blood cells. Both tell us about oxygen carrying capacity. Used to check for anemia or polycythemia.
Fasting needed?
Nope, not for H&H. Ranges vary by age and sex. Source has specifics.
Okay, let's talk lipids. Cholesterol, triglycerides. What's in a typical panel?
Usually measures total cholesterol, HDL, good cholesterol, LDL, bad cholesterol, and triglycerides. Cholesterol is needed for cells, hormones. LDL contributes to plaque buildup. HDL helps remove LDL. Triglycerides are another fat type.
And the clinical significance?
High total cholesterol, LDL, and triglycerides increase risk for coronary artery disease. High HDL is protective. Oral contraceptives might raise levels in some women.
Testing requirements?
Usually requires fasting 12 to 14 hours, water only, no alcohol for 24 hours before. Avoid a high-fat meal the night before. Source gives the target ranges for assessing risk.
Okay. Fasting blood glucose. We touched on glucose earlier.
Right. This measures glucose level after an 8-12-hour fast. Key for diagnosing diabetes or hypoglycemia. Normal fasting is typically 70 to 110 milli-GDL.
Diabetics hold morning meds.
Usually, yes.
Yeah.
Hold insulin or oral meds until after the blood draw.
And the HbA1c, that's the longer-term view.
Exactly. Glycosylated hemoglobin shows average blood sugar over the last 2-3 months because glucose sticks to hemoglobin in red blood cells, which live that long. Great for monitoring diabetes management.
Fasting needed for A1c?
Nope. Can be drawn anytime. Normal for non-diabetics is typically 4.0% to 6.0%. Higher levels mean poorer control over recent months.
Okay. Shifting to kidney function tests. Serum creatinine.
Creatinine is a waste product from muscle, filtered by kidneys. Good indicator of glomerular filtration rate, GFR. If kidneys aren't filtering well, creatinine level in the blood goes up. Avoid excessive exercise or lots of red meat right before, as they can slightly raise it. Normal is roughly 0.6 to 1.3 milli-GBL.
And blood urea nitrogen BUN.
BUN measures nitrogen waste from protein breakdown in the liver. Kidneys filter urea out. Like creatinine, BUN rises if kidney filtration slows. But BUN is also affected by hydration, protein intake, liver function.
So creatinine is more specific to kidneys?
Generally, yes. Often look at the BUN to creatinine ratio, too, for more clues. Normal BUN is around 6 to 20 milli-GDL.
Last lab area. White blood cell count, WBC.
WBCs are our immune defense cells. Total count tells us the overall number. The differential breaks it down into types. Neutrophils, lymphocytes, monocytes, eosinophils, basophils.
You hear about a shift to the left?
Yeah, that means increased immature neutrophils, bands. Often signals an acute bacterial infection. Bone marrow is pushing out reinforcements quickly.
What if the total count is low, but there's a left shift?
Could be recovery from marrow suppression or a really severe infection overwhelming the system. High total count with a left shift strongly suggests bacterial infection or major inflammation.
And a shift to the right.
Less common term means the neutrophils are hypersegmented, seen in liver disease, Down syndrome, certain anemias. Normal total WBC is usually 5,000 to 10,000 per millo. Monitor closely in chemo patients' risk of neutropenia, low neutrophils, high infection risk.
Wow, we've really covered a massive amount of ground there, vital signs and labs. So let's circle back to that opening scenario, the post-op patient with the changing vitals. What's the move?
Right. Based on everything we've discussed, and as the source explains, the absolute first step is crucial. Compare these new vitals to the baseline recorded right after recovery. See how much things have really changed.
Check the trend.
Exactly. Then, quick sanity check. Is the equipment working right? Did we use the right cuff size, etc.? Consider the patient's history, the surgery they had.
Put it all in context.
Yes. But with that drop in BP, rise in heart rate and respirations, drop in O2, especially post-op, alarm bells should be ringing, potential bleeding, shock.
So priority action.
After confirming the readings are likely accurate, immediately notify the RN. These are significant changes needing urgent attention, possibly the surgeon too, depending on policy and the severity. Prompt communication is key for safety.
Really highlights how knowing this stuff leads directly to action. The chapter also has practice questions, right? We can't go through them all, but what kinds of concepts do they reinforce?
Oh, they're great for checking understanding. They hit things like the link between warfarin and INR monitoring, the importance of believing a patient's report of pain, how BUN relates to hydration.
Temperature contraindications.
Yep, like rectal temps in cardiac patients, monitoring APTT with heparin, potassium levels with diuretics like furosemide, knowing which abnormal labs need immediate reporting.
Drug interactions, like with ibuprofen.
Exactly. Interpreting HbA1c for diabetes control, neutropenic precautions, recognizing signs of warfarin or opioid overdose from labs and symptoms, causes of low hemoglobin, normal platelet counts, what to do with abnormal fasting glucose. They really cover the key takeaways.
Sounds like a solid review tool. So wrapping this all up, it's clear that understanding vital signs isn't just about the numbers. It's about that baseline, spotting changes, knowing why they might be changing.
Absolutely. From the nuances of taking temperature to assessing pulse, respirations, BP, pulse ox, and the whole complex picture of pain.
Including non-drug and drug approaches.
Right. And then tying that into understanding lab values, sodium, potassium, clotting tests, blood counts, lipids, glucose, kidney function, WBCs. It all fits together to show us what's happening inside the body.
And for you listening, getting a handle on these core concepts from vitals to labs really does empower you. You can navigate health info better, understand these common assessments more deeply.
You appreciate the story these numbers can tell.
So here's a final thought to chew on. We've seen how interconnected all these things are, vitals, labs, body systems. What subtle changes, maybe just small shifts in one or two of these numbers, do you think might be the earliest clues? The first whispers that something bigger might be starting to shift in someone's health. How might a small change in one area hint at something happening elsewhere?
That's a great question. Makes you think beyond the obvious alarms and look for those quieter signals. The interconnectedness is key.
Definitely something to ponder. Thank you so much for joining us on this deep dive today. We hope exploring these vital signs and lab values has been genuinely helpful. Keep learning, keep questioning.
And reach out if you have questions. Thanks for listening. This really wraps up our look at this essential chapter.